Good afternoon. Welcome and thank you for joining us for today's webinar, How Psychopharmacists Utilize a Novel Approach to Manage Mental Illness Disability, sponsored by Personalized Prescribing, Inc. Personalized Prescribing is a Canadian pharmacogenomics company with a focus on psychopharmacology. Their specially trained psychopharmacists work with patients both on disability or actively at work and their physicians to help optimize their antidepressant treatment. I'm Kristen Dougal, Director of Meetings and Events for Benefits and Pensions Monitor, and I will be your host today. Before we get started, I have a few housekeeping items to review. This is an example of the attendee control panel. You should see something similar on your own computer screen in the upper right-hand corner. Use the orange arrow to open and close your control panel. Use the audio pane to select your preferred audio. Choose computer audio to use your computer microphone and speakers, or choose the phone call option and use your telephone and dial in using the information provided. If you have any questions for today's presenter, please type them into the question pane of the control panel. You can submit them at any time during today's session. We'll be collecting them and addressing them during the audience Q&A portion at the end of the webinar. Use the handouts pane to download the available document. You do have access to download the speaker presentation slides anytime before the webinar ends. Please note that all attendees are in listen-only mode as we'll be recording this webinar. It will be available to view on our website in the next few days. To begin, let me introduce you to our presenter. We have Mark Faiz, CEO at Personalized Prescribing, Inc. Let's jump right in. Over to you, Mark.
Thank you, Kristen. Thank you, ladies and gentlemen. During this presentation, anytime I talk about disability, I'm really referring about disability due to mental illness. And today, ladies and gentlemen, I'm going to take you on a journey on a typical patient that comes to our company. This is a disability patient, although non-disability people also come to us and they have the same kind of journey, but this is a specific disability patient. I'm going to go into the journey, how he came to us, what we talked about. But before I do that, I just want to talk a little bit about a prequel that we had earlier in September, during which we talked a little bit about who we are as pharmacists that are assisted by pharmacogenomics, helping disability managers and insurance companies, bringing people back to work. We presented the fact that antidepressants fail more than 50% of the time, and we presented a finding that almost 100% of all disabled patients that we come across over the last 3 years have very high genetic variation scores. That explains the reason for the high rate of antidepressant failures. And we concluded that the main cause of mental illness disability, is the failure of their antidepressants. Now let's just jump in. So I'm going to be talking about a gentleman called Mike, but that's not his real name. Mike came to us. He's an engineer with a large aerospace company, referred to us by his disability management company. At first, Mike was quite apprehensive. So, our pharmacist engaged with him. We usually need to know a little bit of information as we intake patients. He shared with us that he's been struggling for 4 months, 2 of which he was on disability. He shared with the psychopharmacist that he had a major issue in childhood that we believe probably caused the reason he's suffering today. After the discussions with the pharmacist, Mike became much more comfortable. He decided to go ahead. Of course, our pharmacist absolutely confirmed that his privacy and confidentiality are absolutely protected. No information will be shared with his disability manager or his employer or anybody else for that matter, except his doctor with his consent. Mike then became encouraged. He agreed to proceed. He provided his consent, which we need. He returned his sample, and our lab ran his genetic profile, and we put it through our system. Now, this is the heart of my discussion, ladies and gentlemen. We're now going to go into the actual scientific pharmacological reasons of what happened to Mike and why Mike was on Celexa or escitalopram, the name of the molecule, and obviously he was not having good success with it. His results showed us two very important genes that might explain why Celexa is just not the right thing for him. I'm sorry, I'm going to have to go into a little bit of science, but stay with me. We found that his HTR1A, which is a brain receptor in the serotonin system, is overexpressed. So his variant is not the normal variant that expresses so much of that receptor, but an overexpression of the receptor. We also found that he has the COMT-GG, which is, again, a very overactive version of the COMT-GG. Now, before I go much further, let's actually discuss how does escitalopram normally work? Or for that matter, how does SSRIs, serotonin reuptake inhibitors, work? And the way they work is basically, if you look on the screen, I think you can see my arrow. There's a receptor that is attached to the presynaptic neuron, and that receptor's job is to grab serotonin from the cleft between the two neurons and recycle it back into the postsynapse. Serotonin comes out from the presynapse into the postsynapse. It pinches onto these receptors we call the postsynaptic receptors, and then it causes neurotransmission to continue. Basically, depression is when you have too little serotonin going through the system. And to keep the serotonin in the system, we send escitalopram to attach to this recycler to prevent serotonin from being taken back into recycling, and it keeps serotonin in the cleft, which keeps neurotransmitter continuing moving on. Now, here's the problem. There is this very important autoreceptor here, and this autoreceptor's job is to apply the brakes. Too much serotonin is as bad as too little serotonin. And so what happens, the autoreceptor's job senses that there is too much serotonin, it applies the brake, and it prevents serotonin from flowing into the synapse. So when we give an SSRI, that is escitalopram, serotonin increases in the cleft, which results in the autoreceptor applying the brake, which is exactly what we don't want to happen. Now, what normally happens, though, is that if the autoreceptor is a normal autoreceptor, which is normally expressed, it eventually, the brake shoes, if you like, gets worn out. And as a result, the autoreceptor stops working properly because of this action of the reuptake, inhibiting the reuptake, this applying the brakes, but then slow serotonin back again and again, the brakes begin to wear out. And we call it desensitization. And when that autoreceptor is desensitized, escitalopram starts working because it's now blocking this and it's keeping more serotonin in the presynapse, and the autoreceptor is not applying the brake anymore. That is how escitalopram or SSRIs work. That's why, ladies and gentlemen, SSRIs take a few weeks before they take effect. The reason is because they first have to keep on wrestling with this autoreceptor until it gets desensitized. Now, the problem is why escitalopram does not work for him is that he has an overexpression of the HTR1A. So regardless of how much escitalopram you put into him, there is so much of that receptor, and you're trying to, if you like, wear out a lot of brake shoes, and it just never happens. Now, the other problem is that the overactive COMT, which is this other gene that we found to be a little bit on the high side, what it does is it actually breaks down dopamine and norepinephrine. Another word for norepinephrine is in fact adrenaline. Now, what happens is as it breaks it down, I'm talking about at normal baseline, he happens to have an overactive gene that breaks down dopamine and norepinephrine, which means that this person it has lower levels of dopamine and norepinephrine, which is not a bad thing under normal circumstances. The problem is serotonin, escitalopram actually attaches to this receptor, the HTR3, and it causes the even lower norepinephrine in the system, which means even if escitalopram works for him, it would actually create too low a norepinephrine in the system, which causes another kind of depression. Clearly, in this gentleman's case, we need a different drug. This is escitalopram would not work because of the overexpression of the HTR1 receptor and the fact that the COMT gene is overactive, and it could, even if escitalopram would work, it would cause other problems. So what do? So our pharmacist actually looks, this is a real case, looked at the back end of our software, saw Mike in a very different way, saw all the areas that are causing the problems, could see where escitalopram would not work, looked around and found vortioxetine. Vortioxetine works very similar to escitalopram in that what it does, it also blocks the reuptake here. But what it also does, which is really interesting, it works on the autoreceptor. It agonizes the autoreceptor. Agonizing means it makes it work faster. It pushes it to work harder. As a result, what it does, while it's blocking serotonin here, it also is wearing out the brake faster than normal, which means it's actually overcompensating for the overexpression. Now, the other thing, and remember, we have to deal with the COMT-GG, which is another problem. So even if we get the serotonin to work properly for this man, we are still going to have a problem with norepinephrine. As it happens, vortioxetine actually attaches to the 5-HTR and actually causes it to work harder. It actually causes it to release more neurotransmission in general, but specifically the dopamine or norepinephrine becomes a higher expression, which overcompensates for the low norepinephrine that we started with. That actually solves both problems. As a result, the pharmacist then recommends that escitalopram be tapered off, and we taper it off by slowly reducing the dose over a week or two until escitalopram is cleared from the body and the brain, and then introduce vortioxetine. And that was all in the pharmacist report that went to Mike's doctor, and recommended the vortioxetine start at 10 milligram, at 5 milligram, and a week after pushes it to 10 milligram, and we feel that should work. Now, very quickly, Mike came back and said, look, within a week or two, he's now on vortioxetine, and he said, I've got another problem. I've got a dry eye problem. And that normally happens. It happens. Side effects like that are all over the place. And we assured him that, look, this is a temporary thing. Here's some drops that could work. Stick with it, encourage them to actually stay with it, and explain to them the results will not be immediate. It'll be 3 or 4 weeks, 5 weeks before you see anything. We followed again with Mike 4 weeks after. He reported that he is feeling much better. His energy levels are much higher. He's not as depressed. He still is suffering with dry eye, but he says, look, I'm happy to deal with that because I'm feeling so much better. And at the 6 weeks level, Mike reported that he's feeling so much better and is absolutely ready to go back to work. And indeed, Mike is back at work. Now, Mike, I'm not going to go into this. I'll read it. He gave us this testimonial, and I give it to you unpolished. You can download this and read it at your pleasure, but this man was a very happy camper with our services. Now, at this stage, I must ask you, ladies and gentlemen, was Mike's disability preventable? And I say absolutely. Had Mike been exposed to pharmacogenomics, had his employer had that service built into his health plan, and I will tell you, ladies and gentlemen, a lot of companies are now adding our services into their health plans. I'll mention Manulife as well as Equitable Life, and others are talking about it. Had he had that in his benefit plan, he would have talked to our pharmacist early on, and the spiral would have been broken, and Mike would never have gone into disability to start with. Now, this is the only time, ladies and gentlemen, where I will plug why our pharmacogenomics works better than our competitors. Of course, take me with a grain of salt, try me for sure. But for pharmacogenomics to work, you really need to check a whole bunch of boxes. The first thing, the test, and we do that, the test must test for genes that are responsible for clearance of the drug from the brain. I'm sorry, from the blood before it gets to the brain. So the drug must be circulated and then cleared through the liver enzymes. And if you don't have the right genetic variants there, the drug would fail. Mike didn't have a problem there. The next step is the drug needs to cross the blood-brain barrier into the brain, where it needs to meet up and do its action on the brain receptors. Well, there is at the blood-brain barrier, there's a gene called the PGB protein or the ABCB1 gene, and that gene can, and it's supposed to, the way that gene works is it's looking for any foreign substances trying to come into the brain. And of course, the drug is a foreign substance. So quite often, if the foreign substance, if that gene is overactive, it'll kick the drugs out too fast. Also, there are drugs that brain receptor, the blood-brain barrier recognizes better than others. So you need to make sure that the drug that you actually hope will meet up with the receptors can cross the blood-brain barrier, stays in the brain long enough to do its job, and then gets kicked out. Everything gets kicked out in the end. Finally, you need to test for brain receptors, the HTR1A, the COMT, and all kinds of other ones. And if you don't, you really don't know whether, in fact, it's going to work or not. That's the main subject and focus of my talk today. And finally, and really, please, you really need to have a specially trained pharmacist that will look at the total results and stitch them all together into a coherent one-page report to the doctor that will finally take it and re-prescribe. Doctors, unfortunately, in our world, don't have the time to spend worrying about I'm going to read a 30-page report to try and figure out what this genomic test is trying to tell me. That's the good old way, and it does not work. And for these boxes, we tick every one of them, and very well, if I may. Finally, ladies and gentlemen, our results are exceptional. At the bottom of this page, you will see a button that can take you to our website that actually shows you clients of ours giving their reviews. We have 37 reviews at Google that are, every single one are 5 stars. That's all I have to say this afternoon, ladies and gentlemen. I'm hoping that you have a lot of questions to challenge me.
Great. Thank you for taking the time to share your knowledge and insights with us today. Once again, I want to thank our sponsor, Personalized Prescribing Inc., for their hard work and support leading up to today's webinar. We will now open it up to questions from the audience. So if you have a question for Mark, please type it into the question pane of the control panel. So our first question is, what is the difference between a psychopharmacist and a regular pharmacist?
Excellent question. A psychopharmacist is a pharmacist that is specially trained on psychotropic medication and their genetic interactions. And there is no, you will find the word psychopharmacology all over the place. Unfortunately, there is no specific university that will teach, that will take pharmacists a step further. They just simply, we bring them in, normal, regular pharmacists, and our genetic people will train them, and they read all kinds of information, and they become psychopharmacists, specialists in psychotropic drugs with knowledge of brain receptors and how they work.
Great, thank you. And in your opinion, if this program is so convincing, why do you think the field of medicine, this field of medicine, is not being used by psychiatrists in routine practice?
Because it's a new science. And it's my opinion also that some, and I emphasize some psychiatrists, maybe are threatened. And they shouldn't be, because we don't want to replace them. No, we refer every single patient back to their doctor. We just want to analyze the genetics and tell the pharmacist, the psychiatrist, which is the most appropriate drug. And I'll tell you, while normally most we have very few referrals from doctors. That's true. But we do have some referrals from doctors that have seen our patients. Now they are drinking our wine. So especially psychiatrists, because they speak my language. They will understand when I tell them about the COMP-GG and the HTR1A overexpression and blah, blah, blah. So, however, it's happening. It's going to happen within a couple of 3 years. And I hope that's the case. We will be the standard of practice. I mean, the doctors, psychotropic psychologists, psychiatrists will maybe prescribe the first line medication. But if the patient comes back and says, look, I'm having problems, I believe psychiatrists should go directly to a pharmacogenomic psychopharmacist and ask for help, and that's when things will work much better.
Great, thank you. And is there a listing of a listing of network of psychopharmacists available to Canadians? And if so, where can that be found?
My knowledge is the only real psychopharmacists are ones that work at personalized prescribing, because we've invented that term. We've basically brought 3 pharmacists. We have 3 full-time pharmacists. We put them through a very rigorous training program, and now they are talking the talk. So the list is with us. I can tell you the 3 pharmacists that work for me. Now, having said that, a lot of pharmacists might have some good knowledge in that area, and they might. I mean, there's no level. There's no a pharmacist that will tell you, look, I know brain receptors. I know how they work. I know the pharmacology. I can put it all together for you. But they still need the genetic test to be done. We put everything together.
Thank you. And who do you think would benefit from this service most? For example, would it help people with mild anxiety disorder or social awkwardness, or is it only for the more severe cases?
Absolutely great question. Mild is not our world. Stay away from us. Do not resort to medication the first time around. When you're having a few problems, the first thing you need to do is go seek psychotherapy, because quite often psychotherapy could do the work. If things don't work there, you need to now seek a doctor or psychiatrist that might prescribe you the first line drugs. Remember, I said 50% of drugs don't work, psychotropic drugs, but the other 50% do. So don't come to us yet. Go to your doctor. Your doctor will say, look, let's try this medication. Only if it fails, then you come to us, because look, then it becomes a guess game. And the guessing game could lead you back to into disability. You don't want to go there. Come to us much faster.
Thank you. Does the Canadian Association of Mental Health, CAMH, support your program?
No, we have not gone to them, because CAMH chose a few years ago to partner with a US competitor of ours and did a huge work on it. Unfortunately, they chose a competitor, I don't want to mention names, that don't test for enough genes. They chose a competitor that is not assisted by pharmacists. And as a result, the results were not very encouraging. So CAMH has basically said, oh, well, pharmacogenomics, I don't think it works. And I wish them luck. Look, maybe you'll think that I'm a little arrogant, but I'll tell you, we are more advanced than CAMH when it comes to pharmacology, not psychotherapists. We're not psychotherapists. We are pharmacologists. We're pharmacists. Nobody can do it better than my company. I believe that. So with due respect, CAMH will come to us one day, I believe.
Great, thank you. I think I'll leave it with this one last question for you, and maybe your final takeaway, concluding remarks that you want to share. But with the people that have used your services, what results are you getting with return to work after disability?
Thank you. This is a fantastic question. Look, ladies and gentlemen, mental illness disability, in spite of how brilliant my psychopharmacists are, is a very tough neighborhood. It's very challenging. The brain is extremely complex. We do everything that we can using the knowledge that's available today. The knowledge continues to advance. So I would say we're getting a good 50, 60, 70% of the time people going back to work. Unfortunately, some faster than others. There are 30% of the people that present a real challenge, that we fail, because sometimes they're drug resistant and there's nothing there we can do. There's no drug that would help them. But also their motivation. Some of them are just not motivated to come back to work. So it is, our service is not a silver bullet, but it's a hell of a lot better than without.
Thank you. Unfortunately, that is all the time that we have for today. If your question was not answered, I will be passing them along to the speaker and sponsor company, and someone will follow up with you directly. I want to thank everyone for joining us today. A big thank you to Mark Faiz and Personalized Prescribing, Inc. I really appreciate you joining us today.
Thank
We
you,
hope
Kristen.
we hope that you leave us having learned some new and valuable information. At the end of today's webinar, you will be prompted to answer a short survey. We encourage you to give your honest feedback to help us with future planning. Have a wonderful rest of your day, and please stay safe, everyone. Thank you.